Management of women with premature ovarian insufficiency, 2015 ESHRE Guideline is the topic of our discussion today. How should premature ovarian insufficiency be defined? It is a clinical syndrome defined by loss of ovarian activity before the age of 40 years. Premature ovarian insufficiency is characterized by the menstrual disturbances like amenorrhea or oligomenorrhea with raised gonadotropins and low estradiol level. What is the prevalence of premature ovarian insufficiency in general population? It is approximately 1%. Population characteristics such as ethnicity may affect the prevalence. In the view of the long-term health consequences of premature ovarian insufficiency, efforts should be made to reduce the incidence of POI. Modifiable factors include gynecological surgical practice, lifestyle changes like smoking quitting, modifiable treatment regimens for the malignant and chronic diseases. What are the symptoms of premature ovarian insufficiency? Clinician should inquire about the symptoms of estrogen deficiency in the woman presenting with oligomenorrhea or amenorrhea. POI needs to be excluded in the woman with amenorrhea or oligomenorrhea or estrogen deficiency symptoms below the age of 40 years. What investigations should be performed for the diagnosis of premature ovarian insufficiency? The diagnosis of this condition is based on the presence of the menstrual disturbances and the biochemical confirmation. Although the proper diagnostic accuracy in POI is lacking, the GDG recommends this criteria for the diagnosis. First, oligomenorrhea or amenorrhea for at least 4 months and an elevated FSH of more than 25 international units per liter on 2 occasions at least 4 weeks apart. What are the known causes of POI and how should they be investigated? The chromosomal analysis should be performed in all women with non-iatrogenic premature ovarian insufficiency. Gonadectomy should be recommended for all women with detectable Y chromosomal material. Fragile X premutation testing is indicated in premature ovarian insufficiency women. The implications of Fragile X premutation should be discussed before the test is performed. Autosomal genetic testing is not at present indicated in the woman with POI unless there is evidence suggesting a specific mutation. For example, BPES, blepharophimosis syndrome. Screening for 21-hydroxylase antibodies or alternatively adrenocortical antibodies ACA should be considered in the woman with a POI of unknown cause or if an immune disorder is suspected. Refer POI patients with positive 21-hydroxylase antibody and ACA ratio test to an endocrinologist for testing for adrenal function and to rule out Addison's disease. Screening for thyroid peroxidase antibodies should be performed in the woman with POI of unknown cause or if an immune disorder is suspected. In patients with positive thyroid peroxidase antibodies test, thyroid stimulating hormone should be measured every year. There is insufficient evidence to recommend routinely screening POI women for diabetes. There is no indication for infection screening in women with POI. The possibility of POI being a consequence of a medical or surgical intervention should be discussed with a woman as a part of the consenting process for that treatment. Although no causal relation has been proved for the cigarette smoking and POI, there is a relation to early menopause. Therefore, women who are prone to POI should be advised to stop smoking. In a significant number of women with POI, the cause is not identified and these women are described as having unexplained or idiopathic POI. How often should tests for autoantibodies be repeated? If 21-hydroxylase antibodies versus ACA and thyroid peroxidase antibodies are negative in the woman with POI, there is no indication for retesting later in life unless signs or symptoms of these endocrine diseases develop. So, in these patients, if karyotyping for the diagnosis of Turner syndrome gives the positive result, refer the patient to endocrinologist, cardiologist, and geneticist. In case of the negative result, a second analysis of the karyotype in epithelial cells in case of high clinical suspicion is performed. When we get the positive results for the test for the Y chromosomal material, we discuss gonadotropin with the patient. If we get fragile X syndrome, we refer the patient to geneticist. We also do autosomal genetic testing, antibodies level, ACA 21 hydroxylase antibodies level. If give the positive result, refer the patient to endocrinologist, and in case of the negative result, retest in case of the clinical signs. Thyroid peroxidase antibodies, if positive, test TSH every year, and if negative, retest in case of clinical signs or symptoms. The relatives of women with fragile X premutation should be offered genetic counseling and testing. Relatives of women with non-iatrogenic premutation, premature ovarian insufficiency, who are concerned about their risk of developing POI should be informed that currently there is no proven predictive test to identify women that will develop POI unless mutation known to be related to POI was detected. There are no established POI preventive measures. Fertility preservation appear as a promising option, although the studies are lacking. Their potential risk of earlier menopause should be taken into account when planning a family. What are the consequences of POI for the life expectancy? Untreated POI is associated with reduced life expectancy, largely due to cardiovascular disease. Women with POI should be advised on how to reduce the cardiovascular risk factor by not smoking, taking regular exercise, and maintaining a healthy weight. What are the consequences of POI for fertility? Women with POI should be informed that there is small chance of spontaneous pregnancy. Women with POI should be advised to use contraception if they wish to avoid pregnancy. What fertility interventions are effective? Advise women with premature ovarian insufficiency that there are no interventions that have been reliably shown to increase ovarian activity and natural conception rates. Oocyte donation is an established option for fertility in women with premature ovarian insufficiency. Inform women considering oocyte donation from sisters that this carries a higher risk of cycle cancellation. In women with established premature ovarian insufficiency, the opportunity for fertility preservation is missed. Women should be reassured that spontaneous pregnancies after idiopathic POI or most forms of chemotherapy do not show any higher obstetrical or neonatal risk than in the general population. Oocyte donation pregnancies are high risk and should be managed in an appropriate obstetric unit. Women and their partners should be encouraged to disclose the origin of their pregnancy with their obstetric team. Antenatal and Euclides screening should be based on the age of oocyte donor. Pregnancies in women who have received radiation to the uterus are at high risk of obstetric complications and should be managed in an appropriate obstetric unit. Pregnancies in women with Turner syndrome are at very high risk of obstetric and non-obstetric complications and should be managed in an appropriate obstetric unit with cardiologist involvement. Cardiologists should be involved in the care of the women who have received anthracycline and/or cardiac irradiation. How should fitness for pregnancy be assessed in the women with POI? Women presenting for oocyte donation who are suspected of having POI should be fully investigated prior to oocyte donation, including thyroid and adrenal functions as well as karyotype. Women previously exposed to anthracycline, high dose of cyclophosphamide or mediastinal irradiation should have an echocardiogram prior to pregnancy and referral to cardiologist if indicated. Women with the Turner syndrome should be assessed by a cardiologist with specialist interest in the adult congenital heart disease and should have general medical and endocrine examination. Women with premature ovarian insufficiency should have their blood pressure, renal function, and thyroid function assessed prior to the pregnancy. Pregnancy in some women can be of such high risk that clinician may consider oocyte donation to be life-threatening and therefore inappropriate. What are the consequences of POI for the bone health? It is associated with reduced bone mineral density, which is associated with an increased risk of fracture in later life, although this has not been adequately demonstrated. What are the treatment options for bone protection and improvement? Women should maintain a healthy lifestyle, including the weight-bearing exercise, avoidance of the smoking, and maintaining of the normal body weight to optimize the bone health. A well-balanced diet will contain the recommended intake of the calcium and vitamin D. Dietary supplementation may be required in the woman with inadequate vitamin D status and or calcium intake, and may be of value in the woman with a low bone mineral density. Estrogen replacement is recommended to maintain bone health and prevent the osteoporosis. It is plausible that it will reduce the risk of fracture. The combined oral contraceptive pill may be appropriate for some women, but the effects on bone mineral density are less favorable. Other pharmacological treatments, including bisphosphonate, should only be considered with advice from an osteoporosis specialist. Particular caution applies to the woman desiring pregnancy. How should bone health be monitored in women with POI? It is important to consider bone health at diagnosis in POI and during ongoing care. Measurement of bone mineral density at initial diagnosis of POI should be considered for all women, but especially where there are additional risk factors. If bone mineral density is normal and adequate systemic estrogen replacement is commenced, the value of repeated DEXA scan is low. If a diagnosis of osteoporosis is made and estrogen replacement or other therapy initiated, bone mineral density measurement should be repeated within 5 years. A decrease in bone mineral density should prompt review of the estrogen replacement therapy and or other potential risk factor. Review by the specialist in the osteoporosis may be appropriate. What are the consequences of POI for the cardiovascular system? Women with POI are at increased risk of cardiovascular disease and should be advised of the risk factor that they can modify through the behavioral changes, for example, stopping smoking, taking regular weight-bearing exercise, and healthy weight. All the women diagnosed with Turner syndrome should be evaluated by a cardiologist with expertise in congenital heart disease. Is estrogen replacement cardioprotective? Despite lack of longitudinal outcome data, hormone replacement therapy with early initiation is strongly recommended in the woman with POI to control future risk of cardiovascular disease. It should be continued at least until the average age of natural menopause. Should cardiovascular risk factors be monitored? Cardiovascular risk should be assessed in women diagnosed with POI. At least blood pressure, weight, and smoking status should be monitored annually, with other risk factors being assessed if indicated. In women with the Turner syndrome, cardiovascular risk factors should be assessed at diagnosis and annually monitored. At least blood pressure, smoking, weight, lipid profile, fasting, plasma glucose, and HbA1c. What are the consequences of POI on psychological well-being and the quality of the life? A diagnosis of POI has a significant negative impact on the psychological well-being and the quality of the life. What are the management options for reduced quality of the life associated with POI? Psychological and lifestyle interventions should be accessible to the woman with POI. What are the consequences of POI for sexuality? Routinely inquire about the sexual well-being and the sexual function in the woman with a POI. What are the management options for the effects of POI on sexuality? Adequate estrogen replacement is regarded as a starting point for normalizing the sexual function. Local estrogen may be required to treat dyspareunia. Women with POI should receive adequate counseling about the possibility of using testosterone supplementation so that they can make an informed choice in knowledge that the long-term efficacy and safety are unknown. What treatments are available for genitourinary symptoms in POI? Local estrogens are effective in treating genitourinary symptoms. Clinicians should be aware that despite seemingly adequate systemic HRT, women with POI may experience genitourinary symptoms. Local estrogen may be given in addition to systemic HRT. Lubricants are useful for treatment of vaginal discomfort and dyspareunia for the woman not using HRT. What are the consequences of POI on neurological function? The possible detrimental effect on the cognition should be discussed when planning hysterectomy and or oophorectomy under the age of 50 years, especially for prophylactic reasons. What are the management options for the effect of POI on neurological function? Estrogen replacement to reduce the possible risk of cognitive impairment should be considered in the woman with POI at least until the average age of natural menopause. Women with POI should be advised to take lifestyle measures, for example, exercise, cessation of smoking, maintaining a healthy weight to reduce the possible risk for cognitive impairment. Hormone replacement therapy is indicated for the treatment of symptoms of low estrogen in the woman with POI. Women should be advised that HRT may have a role in the primary prevention of the disease of the cardiovascular system and for the bone protection. What are the risks of hormone replacement therapy? Women with POI should be informed that HRT has not been found to increase the risk of breast cancer before the age of natural menopause. Progestogen should be given in combination with the estrogen therapy to protect the endometrium in the woman with an intact uterus. What are the options for hormone replacement therapy? 17-beta estradiol is preferred to ethinyl estradiol or conjugated equine estrogen for the estrogen replacement. Women should be informed that whilst there may be advantages to the micronized natural progesterone, the strongest evidence of endometrial protection is for oral cyclical combined treatment. Patient preference for the routine and method of administration of each component of HRT must be considered when prescribing, as should contraceptive needs. Once established on therapy, women with POI using HRT should have clinical review annually, paying particular attention to the compliance. No routine monitoring tests are required, but may be promoted by specific symptoms or concerns. Now we will talk about HRT in women with POI and special issues. Girls and women with POI due to Turner syndrome should be offered HRT throughout the normal reproductive lifespan. Now I'll talk about BRCA gene mutation or after breast cancer. HRT is generally contraindicated in the breast cancer survivors. HRT is treatment options for women carrying BRCA1 and 2 mutation but without personal history of the breast cancer after prophylactic bilateral salpingo-oophorectomy or BSO. For the women with endometriosis who required oophorectomy, combined estrogen-progestogen therapy can be effective for the treatment of vasomotor symptoms and may reduce the risk of disease reactivation. Migraine should not be seen as a contraindication to HRT use by the woman with a POI. Consideration should be given to changing dose, route of administration, or regimen if migraine worsened during HRT. Transdermal delivery may be the lowest risk route of administration of estrogen for migraine sufferer with the aura. Hypertension should not be considered a contraindication to HRT use by the woman with a POI. In hypertensive women with POI, transdermal estradiol is the preferred method of delivery. Women with POI and a history of the previous venous thromboembolism or thrombophilic disorders should be referred to a hematologist prior to commencing HRT. Transdermal estradiol is the preferred route of delivery for the woman with POI at an increased risk of VTE. Transdermal estradiol is preferred method of delivery for the women with POI requiring HRT who are obese or overweight. Fibroids are not contraindication to HRT use by the woman with POI. Fibroids are not contraindication to HRT use by the woman with a POI. Women should be informed that androgen treatment is only supported by limited data and that long-term health effects are not clear yet. If androgen therapy is commenced, treatment effect should be evaluated after 3 to 6 months and should possibly be limited to 24 months. What complementary treatments are available in POI? Women with POI should be advised of the risk factors that they can modify through behavioral changes, for example, stopping smoking, taking regular weight-bearing exercise, and healthy weight. Women should be informed that for most alternative and complementary treatment, evidence on efficacy is limited and data on the safety are lacking. How should puberty be induced? Puberty should be induced or progressed with 17-beta estradiol starting with a low dose at the age of 12 with a gradual increase over 2 to 3 years. In the cases of the late diagnosis and for those girls in whom growth is not a concern, modified regimen of estradiol can be considered. Transdermal estradiol results in more psychological estrogen level is therefore preferred. Physiological estrogen levels. The oral contraceptive pill is contraindicated for puberty induction. Begin cyclical progesterone after at least 2 years of the estrogen or when breakthrough bleeding occurs. At the age 12 to 13 years, if there is no spontaneous development and FSH level is elevated, start low-dose estrogen. The preparation includes 17-beta estradiol in transdermal and oral micronized form. In 12.5 to 15 years age, gradually increase estradiol dose at 6 to 12 months interval over 2 to 3 years to adult dose. We have the transdermal and oral preparation of estradiols. At 14 to 16 years, begin cyclic progesterone after 2 years of estrogen or when breakthrough bleeding occurs. The preparation includes oral micronized progesterone or dydrogesterone. So thank you so much. That was all about premature ovarian insufficiency from ESHRE Guidelines. Subscribe on Obstetrics and Gynaecology. Allah Hafiz.